Now, as we know that there has been an exponential rise in the number of patients with diabetes over the years, extending from 2000, and continues to increase every year. We've also seen a complete explosion of newer drugs like GLP-1RA, DPP4 inhibitors, SGLT2 inhibitors, which has kind of sidelined the older drugs like AGIs, thiazolidinediones, sulfonylureas, and metformin. Of these, the main drug that has going to be a focus for today's discussion is linagliptin, which has been in use since 2011. And we have to take that with the perspective that diabetes is a cardiorenal metabolic syndrome with prediabetes and early type 2 diabetes caused by a combination of insulin resistance and beta cell dysfunction, leading to increased glycemia, increased body weight, falling EGFR, and high CV risk, which in turn translates into advanced type 2 diabetes with obesity, insulin resistance, hyperglycemia, dyslipidemia, and NASH. Also, cardiac complications like hypertension, increased clotting, atherosclerosis, heart failure, and coronary artery disease, along with renal diseases like CKD, worsening of albuminuria, which also leads to electrolyte imbalance, which might also cause hemoglobin to be low and causing anemia. So a typical diabetes population has a twofold premature CV mortality and has multiple complications, including retinopathy, neuropathy, and amputations. And about 30% have CV disease, 20% have some degree of CKD, and another 20% have some degree of albuminuria. And as we know, most of our patients with diabetes will be having hypertension, which makes diabetes the largest category on the dialysis register, as well as the largest category on the blindness register all across the world. Now, to treat diabetes, we've got multiple drugs, as I showed you. But if you look at this part of the slide, you will notice that there has been a continuous rise in the usage of a particular group of drugs. And that group of drugs is none other than DPP4 inhibitors. And this has been at the expense of sulfonylureas, which it has somehow overtaken. Even if you look at SGLT2 inhibitors, the rise in the usage of SGLT2 inhibitors has not been that exponential. It's gone up definitely, but not exponential. The GLP-1s have not been that popular. And DPP4 inhibitors have become so popular because they provide with us a simplicity in type 2 diabetes. And if you look at the evidence-based pillar of simplicity, it is a powerful HbA1c lowering agent with a low risk of hypoglycemia. It can be used once daily without need for adjustment. There's safety in heart disease, there's safety in renal and hepatic disease, and it can be used across diverse patient groups in clinical practice. And it is my job today to take you through the journey of all these 5 areas which I have already mentioned. So the evidence of safety and efficacy, I'm sure I'm preaching to the learned. So everybody knows that they're very safe and efficacious drugs, leading to a 0.75% reduction of HbA1c. All of them provide the same degree of HbA1c reduction. And linagliptin, whether you use it as monotherapy or whether you use it as a combination with metformin, it leads to a robust reduction of HbA1c. Naturally, the closer to the baseline, the lesser is the fall. The higher you go, the greater is the fall. So 12.1, you get a 5%, and again, around 12, you get a 4% reduction of HbA1c, which is seen in all molecules and probably a hallmark of diabetes per se. In addition, linagliptin versus glimepiride, when you add on to metformin, provides this additional huge benefit of reduction of hypoglycemia to the extent of about 5 times. It reduces body weight to the tune of 3 kilos with similar HbA1c reduction, which is maintained over a 2-year period and probably longer, which is something we tend to be losing with sulfonylureas. Also, it is useful in patients who have a long history of diabetes, so you can continue to use it over a prolonged period of time, which means it's durable and can be used at any stage of diabetes. As you can see from these slides, that if you use it in patients with diabetes for more than 10 years, it still continues to provide a robust HbA1c with a large percentage of patients reaching the target HbA1c of less than 7.5% to the tune of about 62%. In the elderly, it provides a robust HbA1c reduction like in all other groups. So it can be used safely to reduce blood sugar in the elderly. And also the combination with metformin leads to a 2 to 3-fold increased chance of reaching the HbA1c goal. So as you can see, this is about 2.84 if the HbA1c is lower, and then if you go up a little higher, the chances of reaching the HbA1c is far higher if you use it in combination with metformin in an increasing dose. There is increasing evidence, particularly from the southern part of India, from Dr. Mohan's group as well, that HbA1c is much more susceptible to reduction with DPP4 inhibitors. Again, that is with sitagliptin, and this is data with linagliptin showing a reduction to the tune of 0.9%, whereas if you see in the Western data, it's about 0.7%. So there is probably a bit more robust data in Indo-Asians as far as the usage of DPP4 inhibitors is concerned. We move, therefore, on to other areas like CV and heart failure safety. And of course, this is hedging on the two randomized controlled trials. The CVOT is published with linagliptin, Carmelina, and Carolina. Carmelina looked at 3P MACE and a composite renal endpoint of sustained ESRD, sustained reduction of GFR of greater than 40% and renal death. And Carolina, which looked at 3P MACE and 4P MACE. And what did these results show? Carmelina showed that everything is just about 1, which means linagliptin is completely safe. There is no bad signal. There is also no bad signal with sitagliptin. However, there seems to be a little bit of a bad signal with savertimi. The saxagliptin showed a 27% risk in the increase in the risk of hospitalization for heart failure. Vildagliptin has no CVOT, but the VIVID trial gives an evidence of increased LV volumes and a numerically increased number of CV deaths. Teneligliptin has no CVOT. I will not be discussing teneligliptin any further. And if you look at the QT prolongation, you see that the only drug with absolutely no QT prolongation is linagliptin, even if it's used in a dose 20 times higher than its prescribed dose. Sitagliptin showed some kind of QTc prolongation with 800 milligrams, and vildagliptin with 100 milligrams at 1 and 8 hours. So double the dose led to vildagliptin having this. Teneligliptin, as I said, is not worth discussing. So we come back to Carmelina, which shows an increased risk of hospitalization for heart failure with a history of heart failure at baseline to the tune of 27%. And as you can see, this is 12% reduction of risk, but this did not prove to be statistically significant. But it was enough for the ESC-ESD guideline to take cognizance and say that sita and lina have a neutral effect and may be considered for diabetes patients with heart failure. Saxa, however, is not recommended, and neither is vildagliptin because it has no trial and it increases ejection, it lowers the ejection fraction. So there is also real-world evidence from insurance databases of US and South Korea, which shows that there is a reduction of hospitalization for heart failure when you compare it with second-generation sulfonylurea. These are as robust as insurance database studies can be with the 1:1 propensity matching. If you come to the kidney disease, we know that linagliptin reduces HbA1c all across the board, from mild renal impairment to moderate to severe renal impairment to patients on renal dialysis, and know that. So this can be used safely, and it can also be used in patients with renal transplant. And there is data. There is a composite kidney endpoint in a pre-specified, pre-adjudicated study in the Carmelina. I know it's a secondary endpoint, but it was pre-specified and pre-adjudicated to look at sustained kidney failure, sustained rise of creatinine and renal death. And it also took into account that this was the largest, sickest kidney population with about 60% of renally sick patients in the Carmelina group. If you look at the other studies, they did not have that many patients with established kidney disease. So it did provide long-term kidney safety with, as you can see, all these diamonds are next to the unity, but it did reduce the number of episodes of macroalbuminuria and microvascular composite outcomes, probably relating to natriuresis, diuresis, hyperfiltration, or a reduction of tubular interstitial fibrosis and podocyte loss. There is also this interesting study, the Carmelina study, which has not been highlighted too often, but this is in patients with nephrotic range proteinuria. And as you can see, the number of patients who had increased risk of proteinuria or all-cause hospitalization was increased in the arm which was randomized to placebo, but it did not reach statistical significance. We come to liver disease. Today, NAFLD is starting to become another arm of complications of diabetes with worsening death rates. And most or a large number of patients we find have some degree of NAFLD or NASH. And we see that the exposure relative to normal hepatic function with linagliptin remains the same across the board in this PKPD study. We also know that if you compare it with placebo, it produces a robust HbA1c reduction, which is similar to what it does in patients without liver disease. And this is seen all across the spectrum of CLD, except for decompensated liver disease, wherein, of course, insulin would be a drug of choice. So naturally, it is the first-line treatment in patients with chronic liver disease with no hepatic, with no dose adjustment required. Vildagliptin is not recommended for use in patients with impaired liver function. In addition to all these scientific evidence, we come to practical issues like convenience, and we know linagliptin is excreted mostly unchanged in the bile, and it is highly selective. So it doesn't interfere with anything else, whereas the others seem to be going through the urine. So as you will see in my later slides, they will need dose adjustment. In addition, linagliptin also provides greater than 90% inhibition. It's only linagliptin and sitagliptin which provide this degree of DPP4 inhibitions. The other drugs do not provide this level of DPP4 inhibition continuously. And therefore, we also know that if you do not adjust the dose of DPP4, you can have an increased risk of all-cause death, severe hypoglycemia, and emergency department visits. I wouldn't be taken in too much by this 11.5, 19.2, and 7.4, because these are all database studies, but definitely there seems to be a signal. And in this group of patients who were studied, patients were on Sita and Vilda with unadjusted doses of gliptin. There was no patient on linagliptin, which is, of course, very reassuring. Therefore, we can use it once daily with no dose adjustment, whether it be CKD or CLD, except for decompensated CLD. And it's obviously convenient as a single dose, a simple method to maintain patients on licensed dose without dose modification, which is a bit of a challenge, particularly in our country with so much of problems of follow-up and patients coming back to see you after 5 years with a creatinine which is probably tripled in this 3 or 5 year period. So dose adjustment challenge is removed by the usage of linagliptin. We come to the broad range of type 2 diabetes patients. And this is patients in the continuum of cardiorenal risk. So this is Carmelina. This is high-risk patients in Carolina with lesser risk. So you see that across the board, it seems to be having similar kind of neutral effect in the continuum of cardiorenal risk. We look at the spectrum of CKD, and if you look at 3P MACE, HHF, and ESKD, they're all the same across the entire spectrum of EGFR or the entire overall heart failure. And so in whether you have a worsening CKD or you have similar amount of CKD, you will have the same kind of CV safety and CV neutrality by the use of linagliptin. It can be used in elderly, and in comparison to glimepiride, there is, as you would expect, a bit of a no-brainer, a huge reduction of risk of hypoglycemia, which I'm sure all of you will agree is a huge advantage in the elderly. Also, there is the weight advantage to the tune of about 1.5 to 2 kilograms, which are very important considerations when we have to take into consideration when we are choosing drugs for the elderly. There is no increased risk of cardiorenal events. This is in whether you look at patients between 65 to 75 or whether they are greater than 75. As you can see, all these lines are crossing unity, so there is no increased risk of any kind of event across the entire age spectrum of patients with diabetes. So to summarize, we have linagliptin, which is the broadest clinical evidence in DPP4 inhibitor class. It has highest DPP4 inhibition, about as much as sitagliptin. Similar HbA1c reduction, the unique convenience being once daily, one dose, and efficacy safety data available in a broad range of patients. There are 2 CVOTs and CV safety profile from these outcome trials to back it. There is no increased risk of heart failure, and the only DPP4 inhibitor which has demonstrated kidney safety profile in large outcome trials. I thank you, ladies and gentlemen, for listening to me. Thank you.